Next, I'll be introducing Dr. Wright. He's one of our favorite speakers. We're fortunate to have him come most of the conferences. He's currently chairman of the board at the Pacific Heart Institute in Santa Monica. He was previously director of the Heart Institute at Providence St. John's Health Center in Santa Monica, and he's clinical faculty at UCLA. He earned his medical degree from Harvard Medical School, where he also completed his medical and cardiology training at the Brigham and Women's Hospital. He's currently co-director for the California Medicare Professional Advisory Council. He's chair of the American College of Cardiology Carrier Advisory Committee. He's cardiology advisor for the Medicare Relative Value Update Committee. He's director of the Heart Failure Program at the Pacific Heart Institute. He's director of echocardiography at Providence St. John's Health Center. He's a co-chair of the Heart Failure Specialty Group at the Providence St. Joseph Health System. He was the president of the American College of Cardiology, California, and for 10 years, he served on the medical advisory board at the Los Angeles Zoo, where he served as a cardiologist for a lot of the great apes. Dr. Wright's a renowned lecturer, and he's co-authored the first U.S. guideline on the management of patients with heart failure. He's a recipient of the Specialist of the Year Award from the American College of Cardiology, California, and he continues obviously to be listed in peer surveys as one of the top cardiologists in the state. And we're very fortunate to have him talk today about hypertension, the diagnosis and treatment of the universal biomarker.
Well, thank you very much. I chose this topic because most people think they know a lot about high blood pressure, but we're going to walk through history. I'm going to go back. We're going to talk about how the whole concept of blood pressure and high blood pressure and what it is, because we've sort of not recognized that this is, in the broadest sense of the word, a biomarker. It's how you can determine the health of the vasculature, and importantly, we'll look at data that suggests we can help patients by using this biomarker as an index of how good are the blood vessels and what can we do in terms of medicines potentially to help our patients. These are my disclosures. Almost every company makes drugs in the hypertension world, but most of them are generic, so basically I have no disclosures. So let's take a little walk through history. Here is the famous Yalta Conference, trying to decide what to do when World War II would end, and you can see there Churchill and Roosevelt and Stalin, and they all shared a problem, not just the World War, but their blood pressures. These were their blood pressures the day of the Yalta Conference. And you can see now, the problem in 1944 and 45 is there were no effective antihypertensive drugs, zero. So there wasn't anything to do other than follow the persons. And what happened? All three of them died of stroke, which is strongly related to hypertension. And you can see in 65, 45, and 53, Roosevelt died soon after the Yalta Conference. And he had a White House physician who took his blood pressure twice a day. Here's his blood pressure while he was president. And his blood pressure the day he died was 300 over 190. You know, not much you can do with a patient like that. The reason they didn't treat him is the only drug available to lower blood pressure in 1944 and 45 was phenobarbital, and they didn't want to give a sedative to the guy running the war effort, basically. So let's talk about blood pressure and how we measure it, because I think that you'll find this interesting in terms of your day-to-day medicine. Nobody knew that the blood circulated until William Harvey, back in 1628, described this in his famous monograph of blood circulating. He had no way of measuring blood pressure. There was no way you could palpate, and actually your fingers are pretty good. For those of you who've done this enough, you can get within 10 millimeters or so of what the accurate systolic pressure is just using your finger on the radial pulse. And that's what they did for the next few hundred years. It wasn't until the late 1800s that devices started coming out, and they were actually emulating your finger on the radial artery, trying to decide, okay, how can we measure pressure? But they didn't have an accurate way, and hence when you went to a physician in 1880, no blood pressure was taken. It wasn't until 1896 when an Italian physician invented what you would consider the modern sphygmomanometer, attaching a pressure cuff to a mercury column. That's why we use millimeters of mercury to measure this. But the big change was a decade later when the Russian physician Korotkov described that you could use a stethoscope, put it on the brachial artery, and listen to the artery, and you could hear when the artery was no longer occluded or impacted by the sphygmomanometer. And on the right is actually the first blood pressure cuff. I own this in my collection. In one little vignette, I took a year off to be a medical missionary with a Stone Age tribe in the Amazon. And this was being used by the medical clinic when I was there in 1980. This was their blood pressure cuff, and it was the original cuff from 1912. And they were still using it in 1980. I bought them a modern cuff and brought this home to my collection of medical antiques. Still works. So what they found once you could take blood pressure is this is what your pressure looks like. And we all recognize that as the heart contracts, it elevates pressure to a certain level. That's the systolic. And then between the blood pressure declines until the next beat, and that's the diastolic. And importantly, the difference there we'll talk about is the pulse pressure. And that's a good reflection of integrity of the blood vessels. The problem with blood pressure, as I'll point out in the next coming slides, is that it is a dynamic variable that varies a lot with many things, including even where you measure it. So on the left is if you measure it in the aorta, just after the blood is exiting from the heart. And the interesting thing is that pressure is lower than when you measure it in the arm or in the wrist. And people always say, how's that possible? How is it that an aortic blood pressure is lower than a brachial or radial pressure? And that has to do with the physics and kinetics of reflectant waves. So the blood is pulsatile. It goes down to your hand, for example, and then reflection waves come back up the arteries, and they summate, and that's why the pressure as you go down the arm goes up, actually, not goes down, until you get into the capillaries, as we depict from left to right, and then, of course, the pressure falls further. So one of the problems that faces people is where do you measure blood pressure? Because it's going to vary, and that's going to maybe influence your decision about do I intensify or even start medical therapy, for example. The reason, however, that we're interested in blood pressure is that it's predictive of certain things. So here are 100,000 men who were just followed over time. They weren't treated. This is just an epidemiologic study. And the question is, does blood pressure predict anything? And the answer is clear. From left to right is systolic blood pressure, and this is the death rate from coronary disease. An imperfect metric, as I'll show you in a moment, but that was what the focus was on, 40 years ago when people were first looking at this. Notice that, as Steve Kopecky told you already, the inflection point, if you're an actuary selling life insurance, the lowest death rate for an adult is at 115 millimeters of mercury. So that should be our metric. We used 140 only because in the old days we didn't have effective therapies, but that's where the death rate takes off. The second thing to remember is that although many people focus on diastolic blood pressure is not that predictive. So if you look in blue, these are people that have normal systolic pressures below 120. And if you go right to left is an increase in diastolic pressure. And yes, there's a slight trend there, but the diastolic pressure really doesn't inform you much. Most of the information is contained in the systolic. Look at the pink colors here. The pink colors are people who have systolic of 160. And in fact, the worst group of people are high systolic and low diastolic. That's the tall pink bar in the upper right there. And that's because the pulse pressure tells you how stiff the blood vessels are. If you're young, the blood is expelled from the heart into the aorta. The aorta acts as an elastic reservoir. In between beats, it contracts and propels blood. That's why you have a dicrotic notch, etc. But if you're old, you have stiff vessels. Read atherosclerotic there, and as a consequence, the blood runs off more quickly. There's no capacity in the big vessels like the aorta. That's why the worst blood pressure is 160 over 60, say. If somebody comes in at 160 over 100, their risk is way less than 160 over 60, right? And that's why as you get older, the diastolic blood pressure is less relevant. Hence, our decision-making really should focus on systolic blood pressure. The last thing I want to talk about as we talk about epidemiology is that blood pressure doesn't exist in a vacuum. As per the comment I just made, systolic blood pressure is also going to reflect the integrity of the blood vessels. You heard from Dr. Budoff about calcium in the arteries. As the arteries stiffen and fibrose, then part of the reason they stiffen and fibrose is because of lipid deposition. And it turns out that there's a strong connection between lipid levels and blood pressure throughout one's lifetime. That's what this looks at here. And you have to do all sorts of machinations to correct for age and that kind of thing. But if you just look at some of these, like look at apolipoprotein B, the second one here, that's a better reflector of lipids than is LDL cholesterol. And if you look at how correlated that is with the pulse pressure, the difference between systolic and diastolic, there's a strong connection between lipids and blood pressure. This is one of the reasons why blood pressure is a good biomarker, because it tells you not just what the vessels are like, but it actually gives you a hint as to what the cholesterol is. The other important factor, blood pressure rises with age, at least in our country. So look at the green bar, the green lines, that is systolic pressure. The yellow is diastolic at about age 50. The diastolic starts to fall. Why? Because that's when atherosclerosis develops, and that's when the blood vessels become stiff. But the green line shows that the systolic pressure continues to rise, at least in our country. Look at the Stone Age tribe I worked with in the upper Amazon. The average blood pressure for an adult would be 90/60. Okay? And indeed, if you look there, where I've highlighted in green, for the Yanomamo Indians in Brazil, their average systolic pressure for an adult is 95. Right? If you look down below, the interesting thing is over the next 10 years, if you do epidemiologic of these Stone Age tribes people, their blood pressure does not rise. In fact, over the next 10 years, on average, it falls by 1 millimeter. Look on the far right, our pressures rise every decade. In the US, it's about 0.8 millimeters per year, just under 1 millimeter per year, rising every single year. Now, there's been a lot of assessment of why is this the case? Why is it that people who live a primitive lifestyle don't have a rise in their blood pressure, and we do? Well, if you look at various lifestyle things, and many have been looked at, and everything from those people walk more because if you live in the jungle, you don't have escalators, elevators, automobiles, you don't even have roads, nothing. So you're always on your feet, maybe that's part of it. But a big focus has been on diet, as Dr. Kopecky had mentioned earlier, and some of the focus has been on sodium. Sodium has a huge difference across the world. The lowest sodium intake in the world are people living in the Amazon jungle because there's no salt source there and it rains all the time. So they have a sodium, you talk about a low salt diet going from say 2,500 milligrams of sodium to 1,500. Their average sodium intake is 38, not 2,000. It's so different from our conception. The highest sodium intake in the world is in China, northern China, where their average is 6,100 milligrams a day. But the other thing to point out is that the sodium-potassium ratio is even greater. The sodium-potassium ratio in diet is over 1,000-fold different between people living in the jungle, for example, and people living in northern China or most of America. And that's because when you eat a mostly vegetarian-type diet, you have a high potassium intake and a low sodium intake. So that's why we'll show you later that when you reduce sodium or increase potassium intake, it alters the blood pressure. And which is more important remains very speculative. I'll show you some data about that in a minute. Now, practically, though, when you and I face a patient and making decisions, one of the important things to recognize is the blood pressure is a dynamic variable. It varies by over 100% during the day. Your serum sodium doesn't vary much from 7 a.m. to 7 p.m. or when you're sleeping, but your blood pressure varies by 100%. So activity, talking, day to night, the temperature of the room, depending on whether you have a cold exam room or a warm exam room. There are differences in blood pressure between Sunday and Monday. There are differences winter versus summer. The huge effect, I'll show you in a minute, of the white coat effect or the alert effect that triggers a rise in blood pressure. And even things like when was the last meal? Do they have a full bladder because of all the reflexes that occur in the autonomic nervous system? A ton of different things that affect blood pressure. And this is crucial because most of you are making a decision based on one data point, one time in the day, and that's when the MA or somebody else takes the blood pressure when the patient comes to your office. And we're going to talk about how that can be misleading. It's going to be misleading dependent on the blood pressure device, the cuff size, the position of the arm, all these things that most of us don't really explore but make an enormous difference. And lastly, even selective reporting. Kopecky said, have people take blood pressure at home. Well, they did a really interesting study. They gave people blood pressure cuffs that secretly kept track of the blood pressures. And it turned out patients would take blood pressures and only report the lowest ones to their doctor. So be aware of that. Now, here's a very interesting study about how variable is the blood pressure. This is in an office environment. These people had radial artery lines put in to measure their blood pressure by arterial line. That is still, arterial lines are still the best way to measure blood pressure, but nobody wants to have a catheter put in their artery. But here's what happens. Just the person's blood pressure, when you apply a cuff to their arm, goes up 10 points. That's not even taking it. It's just wrapping the cuff around the arm. As you start the inflation, the average blood pressure goes up an additional 7 points. And this is true at home too. Pushing the button on your home blood pressure sphygmomanometer raises the blood pressure. Okay? When a doctor walks in the room, the blood pressure goes up 20 points. That's the median rise when a physician enters the room. Now, people always say, your patients will say, well, take it again in 3 minutes. Well, it turns out 5 minutes later, the blood pressure is still 12 points higher, right, than it was just before the physician or nurse entered the room. 10 minutes later, it's still 11 points higher. If you have an automatic cuff, that is a blood pressure cuff that the person doesn't have to inflate, hence there's no button pushing, it turns out that according to the arterial line, there isn't any increase. And this is because, think about white noise. Your brain gets rid of the white noise. If you have an automated cuff that's perpetually taking blood pressures every 10 or 15 or 20 minutes, the brain ignores it, and that's the best way to measure blood pressure. And this has been validated with an indwelling arterial catheter. And what that means is that we really should be measuring blood pressure outside of the medical environment if you want to really diagnose whether somebody has hypertension. So here are a bunch of different cuffs. How accurate are they? Well, here's a study that was done. There are very few of these studies, turns out, and I'll show you why in a minute, because manufacturers don't really want you to know that their blood pressure cuff doesn't work because you're not going to buy it. So here is using a particular brand. This one happens to be Oxaline, and this is using it on a machine that generates pressure just to see, is the machine accurate and precise. So here, if you look at 3 tests in a row where the blood pressure was actually 120/80 on this machine, it's not a human, it's a pressure machine. And it turns out this particular machine was both precise, meaning every time you measured it was the same reading, and it was accurate, right? This particular machine was quite accurate. Here's a machine where it was both imprecise and inaccurate. Even though the pressure was 120/80, the readings were anywhere from 100 to 120, and I would argue that a 20 millimeter difference would be enough to influence you about what you're going to do with readings. And here's a machine, this is the most commonly used machine in the United States, the Omron, in which it was very precise. It gave exactly the same readings every time, except they were all 10 points too high. Okay. So, you can have precise machines, inaccurate machines, or a blend of those two. And that's a problem. Another problem, okay? This could be a graph. There's an entire, I'm sure your subscription to Blood Pressure Monitoring Journal has lapsed. I know mine lapsed a while ago. But there's an entire journal of people who do this for a living. And if you look in those journal articles, this is one I pulled out, but there's some even within the last 6 months where you're trying to validate, is my cuff accurate? Well, do you realize that to get a cuff demonstrated to be, quote, accurate, it's a herd accuracy, not for an individual patient. So think about this thought experiment. You and I develop a blood pressure cuff. It reads 10 points too high in every woman and 10 points too low in every man. That cuff is certifiable as being accurate because in the herd, it's within 5 points, and that's the definition of being accurate for purposes of putting the machine onto the market. Here is an experiment using a drugstore and Omron blood pressure cuffs. And I would just point out that if you look at the data points, it's a perfect scattergram. The mean is absolutely spot on. That's how the machines get certified. But for any one individual, you can read 15 high or 20 low or 10 high or 20. You can't predict. And this is the fallacy of thinking that the readings the patients give you are accurate for you to determine, do they have hypertension, and if so, do they need therapy? So what's the solution? The solution is 24-hour ambulatory blood pressure. This is not a new idea. It's just that they didn't have miniaturized pumps and batteries and things until recently. So this was first described in the 60s and they said, turns out this is a better predictor than is office readings or even home readings that patients have. And indeed, in Europe, they did a cost analysis, and it turned out that the charged for you to do a 24-hour ambulatory blood pressure monitor is more than compensated because about 35% of people whom you otherwise would put on antihypertensive therapy don't need it when you do a 24-hour blood pressure. Because what they have is white coat effect. Even their own blood pressure. They push the button, their blood pressure goes up. You think they have hypertension, and they don't. As I'll show you, the predictor that's best is ambulatory blood pressure, not what you get in the office or what the patient gets themselves. So here's what a normal 24-hour blood pressure looks like, and we literally do these every single day. I've read thousands of these. In white is in this particular case, a hypertensive group of people. Notice that during the day here, the average blood pressure in this group was 150. And then at night, it fell down to 130. Those are both still too high. We want the median of all the mean, I should say, of all the readings. Usually when you get a 24-hour blood pressure, we get 60 to 70 readings. We want the average of that to be below 130, preferably 120. I already told you that the best reading is 115, but we might not quibble, for a few millimeters of mercury. In yellow is what happens if you throw a dart to the PDR, if anybody still has a PDR, and you throw that, and wherever it lands in that blood pressure drug, you choose that, you're going to get about a 10-point reduction. If you add a second drug in the light blue color there, you get an additional about 8. The lower you start, the less the blood pressure drug is going to reduce. So if you want to make your blood pressure drug look terrific, enroll people with a blood pressure of 160 because you're going to get more reduction, right? And just keep that in mind if you look at comparative blood pressure studies. Here are the data that tell you, though, that it's the ambulatory blood pressure that drives the bus. So if you look here, these are office readings, 140, 150, and greater than 160, left to right. And if you look at people who have normal 24-hour blood pressures, and this was defined as 130 or less, it turns out that there's not a lot of information contained in just having white coat effect. If somebody's repeatedly over 160 in your office and they're normal at home, they do have a slightly increased risk. Mainly the risk is of developing overt high blood pressure. But look at people that have high readings at home. If your reading is perpetually less than 140 in the doctor's office, but you have high blood pressure here in yellow at home, based on 24-hour blood pressure, your risk of cardiac events is dramatically increased. It's almost the same as whether your office reading is 150 or 160. So you get all the information you need from the systolic reading on home, and you heard about sleep apnea. The other thing we get on a 24-hour blood pressure monitor is that if somebody has elevated blood pressure during the night, then almost always they have disturbed sleep. And that's the group that you need to send for a sleep study or get a home sleep study. In fact, if you read the bottom, the reference standard for confirming hypertension, this is from the U.S. Preventive Services Task Force, is now ambulatory blood pressure. I will not make the diagnosis of hypertension if you came to see me unless you have a 24-hour blood pressure to confirm that you have hypertension. So let's talk about this concept. So first of all, high blood pressure means a blood pressure reading that's elevated. It doesn't mean you have hypertension. In fact, every time you exercise, your blood pressure is going to be greater than 160. Does that mean you have hypertension? Of course not, because the blood pressure goes up during exercise. Hypertension itself probably increases morbidity and mortality in and of itself. But as I started from the outset, this is a biomarker. It tells you about the integrity of the blood vessels. It tells you about catecholamines, about lipids to some extent. So it's a really good biomarker for vascular health. Treatment of blood pressure makes a difference. Think about diabetes. We had 10 classes of anti-diabetic drugs that lowered blood sugar and didn't help patients, didn't make them live longer or better. Now we have 2 classes of anti-diabetic drugs that make the blood test better but also make the patient better. Turns out the blood pressure drugs that you and I use both make the blood pressure better, and as I'll show you, make the patient better. To a point. If you lower blood pressure too much, you're going to potentially harm somebody. And lastly, we're going to explore the data. Does it matter how you lower blood pressure? Is one drug better than the other? Is dieting, weight loss, sodium restriction, are they as good as blood pressure pills? Some of these remain unanswered, but I'll give you some hints as we look at the data. So here's what we used to think. The elevated blood pressure caused atherosclerosis, heart failure, stroke, and kidney dysfunction. It's not really the elevated blood pressure, it's all of this. It's the fact that you have disturbed blood vessels. And those disturbed blood vessels cause all sorts of changes to occur, which then lead to the blood pressure that you and I measure as an indicator that the blood vessels are abnormal, and that's what leads to atherosclerosis, heart failure, stroke, and kidney dysfunction. So what are the causes of hypertension? Well, greater than 90% of people with true hypertension have what we used to call essential. The term has been changed. So where does the word essential hypertension come from? A total misbelief. 100 years ago, some of the physicians said, well, when you get older, your blood vessels get narrowed, so it's essential to have high blood pressure so that you can propel blood through narrowed arteries. And therefore, it's essential, meaning it's necessary. Wrong, right? Completely wrong. That name stuck. They've, in the last 10 years, changed the word to primary hypertension rather than essential to try to get around that misconcept. And that's most of the patients we see. What are the causes of that? We don't know. We know that the kidneys and the brain are involved. That's about as much as we know, okay? The other 10% have all the other causes. The principal one that's identifiable is hyperaldosteronism. We don't usually go to the trouble of measuring renin and aldosterone levels. You can do that if you want, but the proof of this is to give a mineralocorticoid receptor antagonist that blocks the effects of aldo, and it turns out that is a miracle drug for a lot of people with so-called refractory or resistant hypertension. The other things tend not to be even worth looking for, to be honest, unless somebody's an outlier. So is it worthwhile to look for renal artery stenosis and pheochromocytoma and aortic coarctation? Well, the yield in those is so low that normally the answer is treat the high blood pressure hypertension to get the blood pressure to goal, and if you can do that, you don't look. That's normally the case. Now, are there cases we look? Well, of course. If you got an 18-year-old with blood pressure of 200, that's such an outlier. If you have a difference in blood pressure between the arm and the legs, that's an outlier. If the potassium is low on no therapy, that's an outlier. So there are times you're going to look, but most of the time what you're going to do is to treat. So let's talk about treatment. Well, here's one treatment, sodium restriction. It has been highly controversial about whether restricting sodium actually lowers blood pressure, even despite the epidemiologic evidence I said. But here is the best of the studies. And why is this the best? They actually measured sodium in the urine as a measure of sodium intake, and they actually did 24-hour blood pressure. Most of the studies did neither of those, and it's really hard, therefore, to tell. So here's what happens if you put somebody on a week of either high sodium or low sodium diet. And it turns out there is a reduction. It's about 7 millimeters of mercury for systolic if you put people on a low sodium diet. That's after 1 week of a low sodium diet. But look at the distribution in this trial of individual patients. On the right, there are people whose blood pressure went up when you put them on a low sodium diet. In fact, 21% of the people had a rise in their blood pressure when you put them on a low sodium diet. The others had a reduction, and way on the left, there's some people whose blood pressure fell 40 millimeters of mercury when you put them on a low sodium diet. I mean, these are the true hyper responders to sodium. So it's worth doing a little trial like that, because maybe that'll inform you. But most of the patients are going to be 5 millimeters or so of mercury, 5 to 7, something like that, with a low sodium diet. Does that make a difference long term? Well, for low sodium diet, that's never been proven. Why? Because you'd have to put somebody in a low sodium diet for the next 3 to 5 years, and that's virtually impossible to do. But if you look at the blood pressure trials, and here are many blood pressure trials, left to right is the difference in blood pressure, and as you can see, as you reduce blood pressure, the vertical axis is reducing mortality. So is there a benefit to lowering blood pressure? Yes, at least with pharmacologic drugs. So let's look at the drugs. I mentioned in World War II we had no drugs. The first drug that was truly useful, were the thiazide diuretics, which were incidentally discovered, believe it or not, when they were looking for a new antibiotic. And they developed thiazides thinking, that's great, they're going to be sulfa drugs, they're going to be better than sulfa. It turned out they didn't do squat for organisms, but they lowered blood pressure. And the thiazides came into use in the 1950s, and then a whole host of medicines came out over the ensuing decades, including one this year, a brand new one. There are a whole bunch of, we're going to talk about some of these, we don't have time to talk about all of these, but the mainstays are the 4 groups that I've listed here. And those are the old drugs, which are 2, the thiazides and the MRIs, mineralocorticoid receptor antagonists, or you may call them aldosterone antagonists. So the thiazides still have a role. There's a bigger role than you probably imagine for spironolactone or pleuronone and finerenone. Those are the 3 drugs that we have to block the mineralocorticoid receptor. Then, of course, the ACE inhibitors, the ARBs, which are considered equivalent for blood pressure reduction, and the dihydropyridine calcium channel blockers, which in the US really is amlodipine. Nifedipine, of course, is one of those too, but you really should be considering amlodipine. It turns out those 5 classes listed there, will control 97% of all all hypertensive patients. You just have to figure out the dosing and which drugs are best. So let's look at the database for this. First, do you actually have an ROI in terms of lowering blood pressure? Yes, you do. This is a famous study, the HOPE study, in which an ACE inhibitor, in this case it was ramipril, was used. And the tagline when the HOPE study was done was, it reduces cardiovascular events even in normotensive people. That's what they spun this as 30 years ago. Well, it turns out if you look at the data, it turns out the benefit was only in the people that had elevated blood pressure. A quarter of the people had a blood pressure of 124 or less. They didn't benefit from the ACE inhibitor. So it turns out that the benefit of an ACE inhibitor, even though they're said, oh, if you have coronary disease, go on an ACE inhibitor, well, the benefit is really limited to those people who already manifest elevated blood pressures. The higher the blood pressure, the greater the absolute benefit of the ACE inhibitor. What about other drugs? Well, here's a study that I'm amazed that the VA could do this. They took 3,800 vets who had a blood pressure of over 160 to 200, and they randomly assigned them to placebo, or no, who would randomly assign vets who with a blood pressure of 180 to no treatment? But they did this, and they used an ACE inhibitor. But here's what they showed. Turns out that if you use heart attack as the metric, does lowering blood pressure help somebody in the next 3 years, your trial will fail. Because heart attacks are not prevented in the first few years by lowering blood pressure. This is a total number of cardiovascular events as they're primed, but stroke is lowered, for sure, okay? But if you want to show that a drug works, look at heart failure, right? A 65% reduction, essentially, in heart failure in these octogenarians with blood pressures of 160 to 180. So there are certain markers like stroke, heart failure, and kidney dysfunction, which the return on your investment of lowering blood pressure is more rapid. It's not heart attack. And that's been a big bugaboo because a lot of clinical trials were done saying, does the drug lower heart attack? And they go, doesn't work. And that led people to be blasé. But they were looking at the wrong endpoints. You've got to look at stroke, you have to look at heart failure, and you have to look at kidney disease. So let's look at the database for more modern trials. Here's a very large trial, almost 20,000 patients. And the question was, the way they framed this study, these are all older studies, but we can still, through the lens of history, gain a lot. This was, does the old drugs, they defined old drugs as beta blocker and thiazide, or the new drugs, which they defined as the non-dihydroprene calcium channel blocker amlodipine plus an ACE inhibitor, which is a better combo? If you had your choice, should you put somebody on a atenolol plus hydrochlorothiazide, or should you put them on amlodipine plus an ACE inhibitor, or ARB? So if you look at two things, in this trial they also buried in, how about putting all these hypertensives on a statin? Okay? So on the left is what happens to LDL when you put somebody on a atorvastatin. LDL goes down, that's terrific, and it's maintained over the 3 years. On the right is the blood pressure, and these are the various groups. In yellow is a atenolol group, in purple is the amlodipine group. Amlodipine's a little better blood pressure reduction. In fact, atenolol, the beta blockers have been put down a notch. They're no longer considered primary therapies for hypertension because they're not as good as the other drugs. But roughly they're the same. But let me show you what this trial showed. So their the initial thing was cardiac events driven by heart attacks. And they came to the conclusion that a beta blocker plus a thiazide was no different than amlodipine plus brindabel. Why? Because they chose the wrong endpoint. If you actually look at the study, look at the secondary outcomes. Amlodipine-based plus or minus an ACE inhibitor was way better for total mortality, cardiovascular events, stroke, new diabetes, hands down with p-values of less than 0.0001. It was better to put a calcium channel blocker plus the ACE inhibitor than it was to rely on a beta blocker plus thiazides. But the principal headline was you could use that because it didn't make a difference in heart attack. They were just looking at the wrong thing. Second important thing about this, that was maintained at 16 years follow-up. People who were given amlodipine out of the gate versus atenolol had a 27% fewer stroke rate and 34% fewer diabetics, possibly because the beta blockers actually aggravate the propensity for glucose being elevated. Second important thing about this trial, they didn't design the trial to answer this, but it turned out there are additive effects when you add a statin in a hypertensive patient who's not known to have cardiac disease. Here's what happens when you add atorvastatin. And look at, let me go back here. Look at the difference that the amlodipine plus perindopril group, it's synergistic when you add a statin to the calcium channel ACE inhibitor group. The benefit, you've lowered event rates by half. And that's greater than when you use a beta blocker and a thiazide. So for some reason, the combination of these drugs, including a statin, actually gives you extraordinary benefit, lowering the event rates by half over the next 3 years. Another trial, is hydrochlorothiazide added to an ACE inhibitor better than amlodipine? Well, for blood pressure, yellow versus red, amlodipine wins a little bit, not much, only, most of you would argue, 1 or 2 millimeters of mercury. Here's 11,000 patients asking the question, which is better? Well, if you look at outcomes, it's clear which is better. Hydrochlorothiazide is not as good as amlodipine on top of an ACE inhibitor at 21%, and starting at 6 months or less, you have a benefit. So thiazides have been also moved down a notch. They're cheap, but they are not as effective in terms of reducing cardiac events in head-to-head analyses. How low should we go? A huge issue. I alluded to the fact, and Kopecky mentioned, that statistically the best blood pressure in the world is to be 115. That's true. So let's ask the question, if somebody has established hypertension, should we shoot for 130 or should we shoot for 120? So here's the SPRINT trial, another very large, in my view, exceptionally well-designed trial. Let's say you can go to 130, and these are in-office unattended blood pressures, versus 120. Which group does better? Well, the intensive treat with an NNT of 61 people. At 3.3 years, the trial was stopped early because it was considered unethical to keep people with a target of below 140. The target should be 120, and the trial was therefore stopped early, and this is a 9,000 patient trial. In that study, every single group did better with a blood pressure targeted at 120. So, those of you who say, well, the blood pressure is good enough, it's 135 in the office. No. You can get an additional 20% benefit by just tightening the screws a little bit and getting the blood pressure down to 120. What about measuring blood pressure at home? You heard about AFib and wearables and oh my gosh, everybody's going to have the ability. Well, now they have a watch that measures blood pressure, right? And this is something that's embedded. They have a little pressure manometer, and using optics, they look at blood flow and things. So let's see if that actually might be useful for us as clinicians. Well, here are the data. And again, what it says is, this is a relatively small trial, but these mostly are, and this is patients whose blood pressures aren't really high, but they want to ask the question, if somebody goes to the Apple store and buys a watch that claims to be able to measure blood pressure, does it measure blood pressure accurately? So in the lower right, you see what the headline of the study was. Well, 80% of the measurements were within 5 millimeters. And that's true, except here are the raw data. The blood pressures are all over the map. And again, any one reading that says 120, it could be 140, it could be 100. It's plus or minus 20 millimeters of mercury. It's only when you average a whole bunch of readings that you get. So the watches that measure blood pressure, in my view, are not adequate for you and I to make a clinical decision, at least with current technology. Now, what's coming up? We've had all these drugs for all these years. What's coming up? Well, for the first time in more than 3 decades, the FDA just approved a new class of drugs. It's an endothelin antagonist, which had previously been used in this class for primary pulmonary hypertension, for example. Here are the data from a drug approval. Now, I would submit to you that a drug that causes a lot of ankle edema is going to cost a lot of money. Look at the 24-hour ambulatory blood pressure difference, 4 millimeters of mercury. Statistically and epidemiologically, 4 millimeters is important, but we have other drugs that are a lot less expensive and don't cause as many side effects that I think personally that'd be a hard sell. What about renal artery ablation? I mentioned that the kidney is very important because the kidney has receptors, and if the blood pressure is high or low, it will tell the brain to alter the autonomic nervous system and catechol and things. And it does that by sending signals through nerve bundles that travel along the renal artery. Think about it. The kidney is separated from the body. It's on a pedicle. And the only way it has to communicate, it can communicate hormonally, or it can communicate via nerves. The nerves travel, as depicted in this thing, along the renal artery pedicle. So somebody had the idea, let's put a catheter in there and let's burn the nerves or kill the nerves and denervate the kidney, and does that help? Well, it does. The original trials said, oh my God, this is incredible, it lowers blood pressure 15 points. The problem was sham surgery also lowered the blood pressure. Putting a thing in there doing nothing lowered the blood pressure. So you have to do sham trials, because the original trials showed that you improved white coat effect, which probably doesn't really help. But now there are data that if you look at 24-hour blood pressure, you do actually lower the blood pressure using these more modern renal artery ablative techniques. The average reduction is 7 to 9 millimeters of mercury by 24-hour ambulatory blood pressure. And here are the data that show that. In this particular trial, this is the best of the bunch in terms of they got a 12 millimeter reduction, which is of starting at a blood pressure of about 145, equivalent to the best of the oral drugs. So renal artery ablation may have a role. It's just that if you can take a pill that costs $4 a month versus ablate the renal artery, our projections are that probably 5% of people will need renal artery ablation. The other 95% need the physician or nurse or somebody to alter their medicines. That's what I would say. Now, lastly, there's some new concepts coming out. One of them is, well, if ACE inhibitors and ARBs work, and so do mineralocorticoid receptor antagonists, what about if we just get rid of aldosterone? Because aldosterone is one of the things that drives blood pressure. The problem with trying to block, 20 years ago, they had an aldosterone synthase inhibitor, meaning block the enzyme that makes aldosterone. Problem is, that drug also blocks steroid production, because aldosterone is a steroid hormone. They couldn't figure out how do you not prevent cortisol production, et cetera, until this drug. This drug actually selectively blocks aldosterone synthesis. It's an enzymatic blocker. And the initial data looked pretty damn promising. Look at these reductions, right? 2 milligrams once a day lowers blood pressure by 20 millimeters of mercury. And go, that's incredible. But placebo in that trial lowered blood pressure 9 millimeters of mercury. And so it's like, it's not as good as we thought, but still it was exciting. It made it into the New England Journal of Medicine, right, one of our premier journals. And then they did a second study called the HALO study, and look at the reduction. It was 3 millimeters of mercury. So it's like, oh man, again, a new drug, 4 millimeters, 3 millimeters. They're chipping away, but I wouldn't say this is like a panacea. How about RNA therapeutics? All of you are familiar with, look at all the commercials on television these days. RNA therapeutics are a burgeoning thing. There are 24,000 genes. We can turn off any gene we want now. You can tell the scientists that in 2 weeks they could develop an RNA interfering therapy for anything. So they said, let's turn off angiotensinogen production in the liver. This is the protein, this is the precursor for angiotensin and all of the angiotensin family. And let's measure blood pressure for the next 6 months. Now here may be the real deal. In red is an injection of placebo. In the 3 different colors below it are injections of different doses of this interfering RNA turning off angiotensinogen production in the liver. And here you see one shot lowering blood pressure for the next 6 months, right? Because the RNA interfering drug hangs around in the hepatocyte for the next 6 months. Now, is that good? Is that bad? If somebody goes into shock, do they need their angiotensinogen? If they get septic, is that, they actually now have the reversal agent to this in case that happens. So we're not sure, but at least you can lower blood pressure by more than 10 millimeters of mercury with one shot for the next 6 months. So this is probably a harbinger of where antihypertensive therapy is going. But finally, I'd like to close by just saying I love the keep it simple, stupid approach to management of hypertension. So here's what I would say. You want to lower blood pressure, the goal is 120. The best way to measure that is 24-hour blood pressure at home. Choose one on the left, a renin-angiotensin modulator. I don't care if it's an ACE inhibitor or an ARB. They're within 2 millimeters of mercury each other. There are ARBs that are better than other ARBs. Losartan is the weakest. Azilsartan is stronger, so is olmesartan, et cetera. In most, a statin. Now that's interesting. We don't normally think of statin, but the trial showed that if you add a statin to an antihypertensive, the end result is way better because of you're altering the physiology of the blood vessel. And then on the right, one of the other ones. My preference would be dihydropyridine calcium channel blocker, preferably amlodipine, has the longest half-life, cheap, or thiazide sometimes. Now you have to individualize because some people are going to be hypokalemic, hyperkalemic, they're going to have low sodium, this is going to influence you. And on the bottom, if the blood pressure isn't responding, the next best thing to do for sure is a mineralocorticoid receptor antagonist like spironolactone. You might want a beta blocker, but it's inferior in terms of blood pressure reduction. But if somebody has a reason to be on a beta blocker, like they have arrhythmias or something, it would be an appropriate choice. If you do that, you will have a substantial benefit in terms of length of life, quality of life, mainly by preventing stroke, heart failure, kidney failure, and to a lesser extent, heart attack. I thank you very much for your attention.